Any quick comments from the panelists on Dr. Ragi's talk till Dr. Faisal is ready to give the talk?
Yeah, well, it's one excellent talk about the when to do cath or not. So I just have one comment and a question from Dr. Hani Rage. And I will make a comment first. There is a point in the conclusion to do a CT coronary angiography preferred on some of these patients. So I would say in our previous talk from Dr. Rabu, I think the use of a 10 to 15 cc of a coronary contrast is probably giving us a more information compared to CT coronary, where a lot of time we have a non-conclusive finding as well. That's what my experience is, and that's even in states. And the question I have is now, and that's $100 million question, and that is, when we call it the stable ischemic heart disease, because always the question, all these trials coming up with the management of these patients, with the medicines, not going to the cath lab, and these are labeled as the stable. So the question is a very, very, this term, the stable coronary artery disease or stable ischemic heart disease, I think it's a very broad term. And I would like to ask, is Dr. Hani Rage has any further comment about this? How does he define stable in his patient? Thank you.
Thank you very much. Both the comment and the question are great. I'd like to reply to the comment first. If very experienced interventional cardiologists perform catheters on stable patients with 10 cc's of contrast, that's another ballgame. But the majority of catheters are performed by a whole variety of operators. You will get an intervention, you will get somebody trying to perform a catheter who's less experienced, who has difficulty in engaging a right coronary artery because of an anomalous origin, which is not uncommon at all, who plans to use 10 cc's of contrast, but ends up using 150 cc's of contrast. You will also, today, there's a publication, which is, I wish I had it, I would have shared it, on cath-induced coronary artery dissections and what happens. And I think there's nobody on this panel who hasn't seen a VF and cath-induced dissections during diagnostic catheters. So we don't remember those patients. We don't remember the patients with we only remember the ones where we take 30 seconds to cath them and use 15 cc's of contrast. But the others do exist. And the advantage of CT is that you know exactly that you're going to see the anatomy without exposing the patient to the hazards of invasive angiography, which again is not the same in all hands. Now, the other point is absolutely brilliant, which is what is the definition of stable ischemic heart disease? It's a whole spectrum. I think there are 6 subtypes, starting from truly stable patients with no or minimal chest pain, up to patients who've had a STEMI more than 12 months ago and who are symptomatic. And that is why using pretest probability is so important, because we have this umbrella term of stable ischemic heart disease, which includes patients which might be very high risk, which includes patients who are very stable, but who would have a survival benefit from a bypass or possibly from a PCI, and others who may be harmed. So that is what the importance of not using the term to cover all patients without actually triaging them and without looking at the pretest probability, which ranges from low to high. And we have a beautiful SKY calculator for that. And I think, I hope I'm not breaking any confidentiality, I think we're gonna very soon have some excellent material coming up from SKY also, which will be very user-friendly to help us look at those patients.
Thank you. Thank you very much. Faisal, are you ready? You can go ahead if you're ready.
Share my screen. I'm trying to share my screen.
It doesn't seem like sharing.
Okay, one second. Let me try again.
Yeah, try again. I think unshare and share again.
Maybe if you want to go to the next talk, can I troubleshoot this?
Okay, let's do that. So I think our next talk is also a very interesting one. Dr. Key Park from University of South Florida will be giving this talk, which is again, as we mentioned earlier, it's very important for all of us, managing work-life balance, which I think I personally have always felt it very difficult to do it. So hopefully after today's talk, I'll be able to do that. Thank you, Dr. Deepak. Go ahead.
Can everybody hear me and see my slides?
Yeah, we can see your slides.
Okay, wonderful.
And hear you well.
So, great. Thank you so much for this opportunity. And I'll just spend a couple minutes on this topic, which is sort of near and dear to my heart. And hopefully we can get Dr. Latif back on, because I think our talks are complementary. So I don't have any disclosures, however, some caveats. I am not an expert on this topic. I've never given a TED Talk. I have no qualifications per se, but, you know, I think as many of us are, you know, I'm a very busy interventional cardiologist. I do complex coronary work, CTO work, structural work. I'm also a mother and a wife, and, you know, I'll share some experience that I have in regards to managing work and life. And I put the word balance in quotations for now, because I think there may be better terminology for that. But I'll just tell a little bit of my story and how I sort of came to be more interested in this topic. So as many of us know from going through training, it's a long road to become cardiologist, interventional cardiologist. And I was on this road sort of going through routine things, also a young married couple, decided that we wanted to have children, not exactly planned this way, but I became pregnant my interventional fellowship year. And it's not uncommon, especially with women in our field. I unfortunately had a pregnancy complication. My son was born very preterm at 25 weeks. He spent 4.5 months in the neonatal intensive care unit in the middle of my interventional fellowship. So it's an interesting experience and somewhat surreal, and could be a whole talk for a different discussion, but really sort of thrust this whole issue of how do I manage being, you know, a new mother and becoming an interventional cardiologist, you know, sort of managing that training. Fortunately, you know, I worked in a really high-level tertiary care center with an amazing NICU. And after those many months, he came home, and he actually, this is an old picture, he's actually 9 years old now. But he's done wonderfully and is very healthy, and we're very fortunate. So, you know, I only tell this story because I think that it's just a representation of, you know, what many of us go through in very different versions in terms of what we manage in terms of our lives outside of the lab and outside of work. And, you know, we have spouse to consider, we have family, you know, we have children, you know, all of those things in the rest of our lives that go on concurrent to what we're doing in our work practice. And so, you know, when we talk about work life and how to manage everything, you know, there's different components of each side. So when you think about work for us as interventional cardiologists, of course, that's a huge component is being in the cath lab, being in the OR. But, you know, we have clinic duties, our favorite discussions about electronic medical records. I mean, many of us have administrative duties. I'm the fellowship director for our program. You know, we're also trying to, you know, in many settings, you know, advocate for ourselves in regards to research and responsible for teaching as well. And then if you think on the opposite side, we have our lives to manage. Again, many facets of that, and our spouse, our children, our family, our friends, and also I think something that we often neglect to put, and I realize I just put it last on the list when I shouldn't have, is ourself. So, you know, I put the word balance in quotations because if you look at the actual definition of the word balance, it's described as stability produced by an even distribution of weight on each side of a vertical axis. And it really implies that everything is teetering at exactly the right relative weight to each other. And I think that's unrealistic. Whereas opposed to the word integration, I like a little bit better because you blend everything into a functioning unified whole. So I think using the term work-life integration is a little bit more appropriate in terms of what we're trying to do with different facets of our lives. And, you know, this was a term that was coined in the literature a couple years ago. I give this talk to often to women in interventional cardiology, but I think it applies to everybody. And I think that folks in our field are becoming more progressive and realizing that whether you're male or female, or your age, or however it may be, that you need to look at different facets of your life and how to better incorporate everything so that they work seamlessly. And this is different for everybody. You know, in terms of, you know, being in academics and going to conferences, I know some of my colleagues, you know, will often try to bring their family if they can, so that they're not away for such a long time. Other folks I know will, limit their time away from home to 48 hours or less. That is difficult when you are traveling, especially from an area where I'm in rural North Florida. But that's sort of their way that they manage this and try to circumvent that time away from home. So, you think about all these challenges, and it's a lot. So why do we still do interventional cardiology? There are so many challenges. Well, we all love helping patients. I think that's the primary driver that got us into this field. Interventional cardiology is an incredibly dynamic area to work in. We're always developing our procedural skill sets. I think probably no more evident than in the area of TAVR and structural heart disease. Incredible advancements in technology. It's very intellectually stimulating. I personally really enjoy teaching fellows and sort of, growing the new generations of proceduralists. And of course, we also have incredible passion for what we do. So the question I think really is sort of how do we make all this work? And again, not balancing, but making all of these parts of our lives work together. And so it takes effort. Just like any other skill set, I think this is something that needs to be developed and prioritized within oneself to make sure, all of these things kind of go together. And so, these are just things that I think about. When we work in the cath lab, we don't work as a solo operator. I'm not doing an entire intervention by myself. We have techs, we have nurses. Again, we're training fellows. So, when you look at your work and your life, you can't think of that as a solo team. It really takes a village. And it's very similar to the approach we have in the lab. Again, you can't be a solo operator. You can't have a superwoman, Superman mentality. Sometimes I think we don't give our colleagues enough credit that they are willing to help us. We also need to involve our spouse, our family, our friends, whoever we can to help, manage family, kind of do chores, whatever else they can help with. I think nowadays it's incredibly helpful to utilize professional support networks. Many societal organizations have groups that, are sort of really invested in this, finding a good mentor. And, we talk about mentor and sponsorship in our area. But I think you can also have life mentors, people who can sort of help you navigate sort of how to manage these things in your life. Network building, talking to others who are going through similar issues, incredibly important. Societies, like I mentioned, and I find that social media is also incredibly helpful. Again, not to only develop relationships, but also learn what other people are doing in terms of how to manage their work-life balance. What are some logistical things? Some of these I think are easier once you've progressed in your career beyond your first couple of years. I still find saying no incredibly hard to do, but it takes practice. I've also realized that if I've overcommitted myself, the quality of work that I'm doing for certain projects is not 100%. So at this point, I try to really commit to projects that I'm really interested, really invested in. I know that I have the time to do them well, because otherwise, you don't want your reputation in your work to suffer. In terms of at home, I think that everything that you are not needed for, and if you're financially capable, which I know not everybody is, but really outsource work. So we made a decision a couple years ago to hire cleaning services for our home. It's been life-changing. These people that we hire are experts at cleaning. I don't want to know how they clean things, but they do an amazing job, and that's what they're good at. And I get my, 3 or 4 hours back of my time, which at this point is incredibly precious and worth it to me in terms of the monetary investment. I also find that it's incredibly important to plan ahead. So you need to know when you're in the lab, when you're responsible for childcare, plan weeks in advance. The other thing I think is important too is that work versus life, again, it's not a balance, and it's always going to be teetering. So at certain points, work will predominate. At other points, life will predominate. And so it needs to be just sort of understood that, it's going to vary between time points. When I went up for academic promotion, my husband knew that I wouldn't be present for a while after hours, just because I was really busy doing other things. And so just, a couple last wrap-up slides, and I mentioned this, but it's incredibly important to prioritize your self-care. And I think when we think about what we do, this is last on the list, but we need to take time off. We need to prioritize that. We need to have hobbies, you know, work out, you know, take care of your own health. I gave this talk last year, and this is an example of how us as physicians are also often the worst patients. But I given this, you know, almost identical talk and discussed all these elements, and yet I did not listen to myself. So in November of last year, I had to stay out of work for 3 weeks because of a herniated cervical disc. I was bedbound for a week and a half. I could not get up without assistance from bed. And it was a really interesting, eye-opening experience for me. And so it's a constant struggle, even after this and with recovery. I still don't take ideal care of myself, but you know, it's a constant process. So again, I'm not an expert in this clearly, but you know, it is a continual effort to learn and improve. So with that, you know, I'll thank my sort of home team and all of those who supported me, including my family and my friends. And again, thank you all for your time and opportunity to speak on this topic. Thank you.
Thank you so much, Dr. Park. It was a great talk.